Hello and good afternoon, good morning, wherever you are. And you are all most welcome to today's presentation. I am Wisdom Akurugu, and I'm happy to be moderating today's webinar. And we are privileged to have a guest speaker who was a member of the Scientific Advisory Board of H3A Bionet Consortium, in the person of Professor David Roos. Prof Roos is the E. Otis Kendall Professor of Biology at the University of Pennsylvania in the United States of America. He's affiliated with graduate programs in microbiology, virology, and parasitology, genomics and computational biology, cell and developmental biology, and bioengineering. He has obtained degrees from the Harvard College and the Rockefeller University. He did a postdoctoral study at the Stanford University and joined the University of Pennsylvania in 1989, when some of us were just about 9 years. I'm privileged to be hosting him today. He received several awards, including the Merit Award from the National Institute of Health. He has over 250 scientific reports and successfully supervised over 25 PhD students and 50 postdoctoral fellows. One of the key output of his lab is the clinical epidemiology database, which is the focus of his talk today. Prof Roos, on behalf of the Webinars Organizing Committee and everybody who is listening to us today, we are privileged to have you and we welcome you to make your presentation.
Well, thank you very much, Wisdom. Can you hear me and see the screen okay?
Yes, we are fine.
Very good. Well, thanks very much to you and to Nikki and others for the invitation to speak to this group. I think we are joined by people from a variety of sources, from the H3 Africa Bionet Consortium, of course, also from the Institute for Infectious Disease and Molecular Medicine at UCT. And I believe we also have some participants who have joined from the Pan-African Malaria Control Association. So a variety of different backgrounds and different interests. I trust that there are people here on the call who may be interested in the ClinEpiDB resource that you see on the screen as a platform for exploring their own data or for exploring the epidemiological and field data of others. There are others on the call, bioinformaticists with the H3A Bionet program and likely with the Elwazi and African Open Bioscience Project that Nikki has been promoting, who are interested in this as a platform for new development and ways that they may be able to assist. And I hope that we will be able to address all of these in some measure. And I am joined in this presentation by my colleagues Danica Helb and Nupur Katur, who will also give part of the talk. I do want to spend most of my time today talking about the ClinEpiDB database, which is a resource that is likely new to most of you, including those of you who I have known for many years. And I wanted to spend just a couple of moments providing a little bit of background. Some of you may be more familiar with the widely used genome informatics platforms that have grown and expanded over the years, now represented by the Viewpathdb database representing the vector and eukaryotic pathogen, vector host and eukaryotic pathogen database resources that have been supported by a variety of funding sources, and for over 20 years. For those of you like Winston, for example, who were barely born 20 years ago, I'll point out that the earliest version of this database was released in CD format, now long obsolete, but a database that even a few years ago I did still see being used. This CD was distributed to all high school students in Senegal by the government at the time. It came out as a way of trying to promote engagement with modern informatics science on the African continent, something that we have certainly been very committed to. I will not be spending my time today talking about our genomics resources, which are quite well known and widely used, but simply point out that the philosophy underlying these resources to provide researchers with the data and tools to ask their own questions permeates our work on clinical and epidemiological data resources as well. Over the past 20 years, the number of databases associated with this project has proliferated as represented in the icons shown down below and also on the following slide, in which our goal is to try to expedite global research through the Viewpathdb family of databases, including databases responsible for host genomic information, whether that's information from humans, model organisms like mice, or the targets of crop pathogens like maize and rice. And these resources combine information on genes and all of the functional annotation and genomic studies associated with them, here represented by the fungal database. But most importantly, the ability to dynamically query all of the vast wealth of information that we are all privileged to be able to explore from the organisms of interest. Shown here is what we call a query strategy, allowing users, in this case from a study that was done not by me, but by Kevin Tete, then working in the Gambia, the MRC in the Gambia, and Isabella Ochoa, then working at Kemri, I believe in Kilifi at the time, to try to identify candidate blood stage vaccines in malaria parasites. In the past few years, these parasite resources have merged with a vector-based project, also supported as a bioinformatics resource center by the US NIH, which in addition to supporting genome informatics resources, has also provided mapping functionality in order to be able to track mosquito surveillance and provide integrated analysis of that data in ways that are now being integrated into the epidemiological platforms that I'll be talking about today. I won't be talking about any of these resources that I've highlighted thus far, choosing instead to focus on one of the newest of the database resources that we've developed, a project that's just a few years in standing. In fact, some of the people on this call were with me at H3A BioNet meetings when we discussed our efforts to try to develop what has now turned into the clinical and epidemiological database, ClinEpiDB, which has been an interesting educational experience, but whose goal is to manage and facilitate the exploration of high quality, large scale data sets, not from genomes per se, but from field clinical and epidemiological studies. And that has been an interesting experience, but leveraging the available technology has allowed us to put together tools that I hope and trust over the coming 20 years will be as transformative for such large scale studies in the epidemiological arena as genomics resources have been for basic laboratory research over the past generation. I also won't be talking about a parallel development on the MicrobiomeDB project. We may touch on it towards the end, but I'm certainly happy to take any questions about these at the end of the presentation today. Or you will note on the top of all of these pages is a Contact Us link. And if you were to click on that link, it will enter into our tracking system to make sure that I or whoever is appropriate gets back to you. Now, as many of you are aware, these resources are quite widely used, receiving something on the order of 100,000 visits per month to various databases. We serve up many terabytes of data every year. and usage is worldwide. Interest in the Plasmodium genome database is not surprisingly takes heavy advantage of interest in the malaria belt across the world, including both East and West Africa here, Ghana and Kenya, South Africa as well, but many other sites. And as one might expect, the interest in kinetoplastid parasites is particularly focused in South America, interest in amoebiasis in Mexico, India, and East Asia. I, for one, was a little bit perplexed to discover the high interest in the Microsporidia database in East Asia until I discovered that Microsporidia are the major pathogens of the silkworm industry. This different representation is indicated down below here. Much of the interest in South Africa is focused on malaria, and so we will start by talking about some of the malaria data in the epidemiology resources today. These databases have been cited, are cited thousands of times per year, a cumulative citation rate of greater than 25,000 citations. But the important thing to keep in mind about this project is that all of these various database resources involving investigators in various places in the world, in North America, South America, Europe, Africa, and with occasional partners in South Asia as well. Many individuals and many institutions, all working on a single project, organized into various performance teams focused on data processing and loading, systems and database administration, user interface development and infrastructure development, curation, and our scientific outreach team. But the development of the epidemiology resources required that we put together an epidemiology team and supported by a professional ontology development staff, and you'll hear a little bit more about those later on. I'm joined today by two of the three leaders of the Epidemiology Project, Danica Held and Nipur Katur. So what I would like to do is spend a few minutes showing you some of the research questions that malaria researchers might be interested in exploring through the ClinEpiDB database, just using pre-configured queries in a PowerPoint presentation. I will then turn the stage over to Danica Held, who will walk you through some of these resources live online, as everyone on this call is aware, using a platform presentation for representation of a dynamic web resource is a little bit silly, and we urge all of you to explore the ClinEpiDB resource on your own. I've neglected to mention that while many of these resources that I've indicated by the symbols down below are very heavily used, as the usage statistics moments ago will indicate, the ClinEpiDB is a new resource, and we are eager to try to promote awareness and usage of this resource by data providers, by students, by researchers worldwide. If you go to clinepidb.org, you will see scores of studies that have now been loaded into the database, including many large-scale studies which are still in progress, those that are grayed out, but for which you can get a peek of the information that is coming. And as with all of our genomics resources, we also endeavor to provide tutorials and example analyses that allow you to dive in and look at the data, but modifying that, twiddling the parameters on your own. Just by way of introduction, I'll say a word or two about about some of the projects that we have explored with colleagues in Uganda, from Moses Kamya's group at the IDRC, working with Grant Dorsey under the UCSF under the auspices of the International Centers of Malaria Research Consortium. Clicking on one of these resources allows you to dive into the study itself, initially using the first PRISM isomer cohort, this program for study of malaria in Uganda. And the study details provide extensive information about the study itself, the nature of the disease, how long, when it is carried out, the number of households and participants, and so on. key publications, information about the study, location in which this was carried out, in this case, a study designed to identify the evolution of functional resistance to malaria over the course of childhood in individuals in a highly endemic area with year-round transmission, links to the individual investigators, and this particular study has been generously made available without restriction by the data by the data providers. But as with our genomics sites, and particularly with the challenging issues associated with field data, we do have a robust data control and policy, which is quite straightforward. We always trust that all data belongs to the data providers and is only made accessible to the extent that those data providers permit. And we have a variety of controlled and protected mechanisms for ensuring appropriate access to the data, which we can discuss later on if you're interested. But let me take just a couple of minutes to show you something about what it is that one might want to do with these resources. In this particular query, you can see an entity diagram indicating the representation of households, participants, and samples, some of which have been tested multiple times, and individual variables that are featured. In this case, looking at symptomatic malaria, I can see very rapidly in this study 6,000 diagnoses of malaria, representing most of the participants in virtually every household in the study. Other featured variables include the need to look at individual regions, not surprisingly in Ngongera, in northeastern Uganda on the Kenyan border, very high rate of malaria, less so in the peri-urban areas around Entebbe. But many other variables as well, as you can see scrolling by on the left. On the right, I'm looking at the population structure and can see that most of the malaria is in children, as one might expect. In this particular study design, it included children under the age of 10, as well as individual caregivers in some of the in the households where those children live, but also information on socioeconomic factors, on entomological parameters, and so on. Those from the Pan-African Malaria Control will be interested in information on the counts of Anopheles mosquitoes, and we have now endeavored to embed analytical tools directly within the platform, allowing, in this particular case, an exploration of the frequency of Anopheles funestus versus Anopheles gambiae. We can see an inverse correlation here, and in this case, I have stratified this by dwelling type, with much higher mosquito abundance in traditional dwelling types than in more modern housing, as one might expect. I could segment it further to break this apart by individual location, or select only the children from the study, looking at the incidence of malaria in these individual over time in the three field sites that were studied, Chihihi, Ngongera, and Wallakuba, and further identifying by household type to look at over the duration of this study. Note the much higher incidence of malaria in traditional houses than in modern housing in Chihihi, but less so in Ngongera and Wallakuba, and allow us to dive into the data to explore the reasons for that a little bit further. Now, these kinds of analyses, which Danica will highlight for you a little bit later on for other studies, are saved so that I can go back in and look at them in individual ways. I can explore this data on other sector data sets, in this case, looking at symptomatic versus asymptomatic malaria, allowing me to track with children over at various ages that as the incidence of malaria declines, that happens concomitantly with an increase in asymptomatic parasitemia, with important implications for control. If we were to turn to the more recent cohort study that has looked at individuals of all ages throughout these communities, looking at the evolution of asymptomatic malaria, I can observe that the incidence of malaria has declines with age and has also declined over time with the with spraying campaigns, but that asymptomatic parasitemia continues to be observed over the entire duration of this study, allowing me to configure a query asking about the incidence of effective infection with malaria parasites in mosquito midguts as a function of the density of gametocytes observed in the study subjects from whom blood was drawn for membrane feeding experiments in the field. And stratifying by age, this allows me to see that that children in the 5 to 15-year-old category, while they have a relatively low incidence of malaria, are the predominant carriers of gametocytes and therefore the predominant source of malaria for transmission, with obvious implications for public policy and control. So this, I hope, is an illustration of the kinds of research questions that are readily accessible through exploring epidemiological studies in this kind of a platform. Let me turn the platform over to Danica, who is going to walk you through some other examples live and online. I think, Danica, I need to stop sharing my screen, and you should be able to share yours, and we'll be happy to take any questions at the end.
Thanks, David. So I'm getting a message that the host has disabled participant screen sharing.
So Wisdom, if you could permit Danica and Nupur to both share their screens, that would be great.
Yes, Danica, you can try yours.
Okay, great. Thank you. I'll give it a shot. Yes, it's working now. Okay, great. So I'm going to take you through a few demonstrations using ClinEpiDB. And so everything that I'm showing you today is accessible to you all. You just go to clinepidb.org and you can perform the exact analyses that I'm doing right now on your own. So the first thing is, like David mentioned, we've integrated a number of different studies. And a quick way to get a summary of what types of data are available is to go to the study summaries table over here. Just give it a second to load. Okay, so in this table, you can see that we currently have 36 studies in ClinEpiDB, and you'll see a name for all these studies here on the left. And then an indication of the type of disease. So if I scroll down, you see we have a number of malaria studies, diarrheal studies, schisto studies, respiratory conditions, different topics. And then you can also see that with the study design, we have the ability to integrate many different types of study designs. So cohorts, case control studies, cross-sectional studies, and even clinical trials are all there. You can get a bit of a sense of the sample size. So here we're listing the number of participants that each study surveyed. And then in the country, we are indicating the locations where that data collection occurred. So there's a lot of information here. Something else to be aware of is this data accessibility, study accessibility column here. And so this is an indication of whether or not you're going to be able to download the data right away, or whether you should ask permission to get access to that data. So I think Nupur will go over this a bit more in her presentation, but if we just scroll through, you see a number of protected studies. These, you can always view all of the data on our website in aggregate. So, you know, population means, that's all accessible. But if you wanted to either download the data to perform analyses on your own, or to look at individuals to see one person's data, you're going to have to ask for permission from the original study team. So the study teams that provided us with this data are always the owners of the data, and we make sure that they're comfortable with who's accessing their data. So the protected studies, you do need to request permission. The public studies are freely available on our website right now. You can go online. You don't need to tell anyone that you're downloading the data, and you can access that yourself. Pre-release ones we're working on right now in the background, and then controlled access. Our study providers just want to know who's accessing the data and what their intended purpose is, but you can immediately after you submit those data access requests, you can go ahead and download that data as well. So David showed us some results from the PRISM study, which is a longitudinal malaria study. So I'm now going to show off the lineup study. So this is also a malaria study, but instead of being a longitudinal study, this one is a clinical trial that was embedded in Uganda's national long-lasting insecticide-treated net distribution campaign. And so, like David mentioned, on this view study details page, I can scroll through here before I start looking at my data to get a better sense of the methodologies used in this study. So I'm not going to take time to do this right now, but I will tell you that this study in Uganda, they have achieved near universal coverage with LLINs. But unfortunately, this has not had the desired impact on malaria burden. And so they are hypothesizing that this could be potentially because of pyrethroid resistance in those nets. So this lineup study was looking at the effect of combining pyrethroid insecticides with PBO, which is a synergist, to see if it would reduce malaria burden. And so I'll go over to the Browse and Subset tab, and this is where we can access all of the data. Again, as David mentioned, we've pulled out key variables into this featured variables box. These are the main studies that we think most people will want to be aware of, no matter what they're interested in analyzing. And so for this study, we have the as treated study arms. And so we have the PBO LLANs and then the non-PBO LLANs. So again, the PBO is the synergist that's hoping to improve the efficacy of these pyrethroid insecticides. So some other studies, some other variables that are interested are the cluster as treated, not dichotomized. So this study looked at different brands of the PBO nets and the non-PBO nets. And then this study collected data at multiple time points. So again, we have data collected at the pre-intervention baseline before these bed nets were distributed. And then follow-up surveillance was conducted at 6 months, 12 months, and 18 months. And we have the distribution of participant ages under the study. So you could see that they were surveying participants ranging from near birth to 110 years of age. And then the main outcome of this study was whether Plasmodium parasites were detected by thick smear microscopy. So we have that there. And then there is quite a breadth of additional data available depending on what your interests for secondary analyses might be. So I'm just going to scroll through this list of variables briefly just to show you the types of things that are available. So we have information on the baseline cluster characteristics such as parasite prevalence in each of the clusters. We have data collected on the households, more data collected on the particular insects that were collected in each of those households. And then data on the universal coverage campaign, data on bed nets. There's a ton of information here. And so this is a great resource for doing secondary analyses that were not included in the primary publication. For example, perhaps you're interested in looking at cooking fuel in an analysis. So, I'll start going through how to do an analysis on the site now. So one feature that I really like is, since there are so many variables, I like to get started by starring the variables that I will use in my analysis. So you'll see these stars here, and I'll just click the ones that I am going to be using here. So I'm going to be using cluster as treated, dichotomized, household study time point, Plasmodium by thick smear microscopy, and then I'm also going to look at uptake variables, so ITN usage. So let me just find those. ITNs. So you can see I have this search bar, so I can easily find what I'm looking for. And I'm starring all of these. And So now that I've starred these variables, I can switch from viewing all of the variables to just the variables I'm interested in. And this is a much more consolidated and easily navigated list. So I recommend using that feature. It's really a nice feature. Okay, so let's just start taking a look at these variables. So first off, cluster as treated. You can see that the clusters predominantly received either PBO LLINs or non-PBO LLINs. And then there are some clusters that received a combination of both types of nets. And those are going to be less interesting for my analysis. So I'm going to select the PBO LLINs and non-PBO LLINs so that I can really see the differences in clusters that received either the PBO treated nets or the non-treated nets. So I've made those selections, and if I go up here to my entity diagram, you can see that I don't know if you can see this, but there's a pink bar on the bottom, and there's a bit of gray at the end. So the pink represents the data that I've selected with my filters, and the gray represents what's not been selected. So gray here is the clusters that did not receive a predominant type of LLIN. So we can see that there were 104 total clusters in the study, and 101 of those received predominantly either PBO or non-PBO LLINs. And so you can see this also is filtering out the households and participants that live in those clusters where no predominant LLIN type was distributed. Okay, so yeah, so let's just take a peek at the Plasmodium outcome results. And so for this, we can see a definition of this variable. So this variable is looking at whether Plasmodium parasites were detected by Thwix smears. And these were only assessed for participants who are eligible for the clinical survey. So you could dig a bit into the study details to figure out who's eligible, but I will just tell you right now, it is children. So you can see that they, you know, the children who had received either PBO LLIN or non-PBO LLIN, we had about 5,000 that tested positive for Plasmodium microscopy in this study. Okay, so I'm going to now move over to the Visualize tab and take us through some analyses. So the first thing you'll see in the Visualize tab is that you have a breadth of tools that we've developed for you. And we've tried to make these very easy point and click tools to be able to configure these plots. And so I'm going to start with the line plot for this analysis. And so I want to look at uptake of whether or not people are owning and using the bed nets. So I'll just configure this plot. You'll see that here I have drop downs to select my X and Y axes. So for my X axis, I'm going to just look at my starred variables, and I'm going to select the household study time points. And I'm going to select household ITNs. And then it's asking me to configure my proportion, and I want those subjects that had bed nets. So you could see that we have pretty good coverage everywhere. And I see that David's sending me a note that I need to finish up soon. So I won't take you through the other uptake variables here, but I will take you to look at the outcomes quickly. So this time in my line plot, again, I want to look at the study time point, and I'm going to look at Plasmodium thick smear, and I want to look at parasite prevalence. So I configure that. And then I don't want the ones who were not tested. So yeah, so we could see that there is a decrease in prevalence, but now I want to look at my two study arms. So I'm going to look at cluster as treated, dichotomized. And if I zoom in here, you can see that there is slightly higher parasite prevalence in clusters that received the non-PBO LLINs. And so I'm now wondering whether or not the brand of LLIN matter. So instead of cluster as treated dichotomized, I'm now looking at cluster as treated. And again, I'm going to zoom in here so I can see everything a bit better. And the two PBO nets were the Olyset Plus and the Permanet. And so, you know, here I can see that there does seem to be a difference in the effectiveness of these two brands of PBO nets. And so this might be something that I explore further by designing a follow-up study where I'm giving these two types of brands of bed nets to see if there actually is a difference between these two. I had wanted to also take you through the GEMS case control study, but I believe, David, that we don't have time for that. Is that correct?
Well, I think we may take some time. It really depends on what people's interests what people's interests are. We realize that there's a wide range of interests of people on this call, from people who are field researchers to those who are bioinformaticists, those who are epidemiologists, and those for whom this is new kinds of data. So maybe what we'll do is thank Danica for this walk through the lineup trial. I think she was planning on walking through additional data from a case control study on enteric disease, but we also support data on helminth infections and on a variety of different sorts of clinical trials from various places in the world. But I think Nipur was planning to had put together some slides to try to summarize what we have done here. Let's try to do that, cognizant of what the time is, and then we can come back for any additional questions about the resources that Danica has been showing or that I had shown, or other questions about discussion topics that Nipur had put together. Nipur, I think you should be able to share your screen.
Yes. So let me share my screen. So do you see my slide now?
We do.
Okay, great. So hi, everybody. You've heard from David and Danica, and in the last few minutes of our presentation, I will briefly summarize what David and Danica have shown you and lead us into a discussion. So the Viewpathdb project is a global team of over 75 people, including scientists and software engineers, who build production quality tools for working with data. And ClinEpiDB is one of the newest additions to the Viewpathdb family of data resources. And it leverages both their infrastructure and their 2 decades plus years of experience. So here you can see us alongside the more established genomic resources, including CryptoDB, Plasmodium, and Vectorbase. So like the other Viewpathdb platforms, we provide a database specializing in clinical and epidemiological data. And we don't just provide the data, we offer data mining tools with a very simple user interface that anybody can use by just pointing and clicking. We also invest in education and outreach activities like conducting workshops and attending conferences. So ClinEpiDB allows you to do 3 main things. The first is to share your own data responsibly. The second is to explore data right in the browser using our interface and tools. And third, you can download data from other researchers for secondary analysis. So taken together, our goal is to promote and facilitate data sharing. Let's take a step back and consider, why is it worth thinking and talking about data sharing? One reason is that data sharing benefits our field as a whole and promotes transparency and high quality research. It enables secondary data use, it prevents redundancies, it increases efficiency, and altogether helps us design better studies. And what's more, data sharing is increasingly a requirement for researchers. Funders require you to share data in order to preserve research outputs and get the most out of their investment. And journals require data sharing because of the need for transparency and reproducibility in research. But we do want to make the point, however, that data sharing isn't just about compliance. It benefits you, the researchers and the data producers, by fostering collaborations and making your work more visible and fruitful. Data sharing is not yet the norm in our field because it does come with a number of challenges. There are ethical challenges with protecting the privacy of research participants and the question of how to be fair across the board to data producers and to stakeholders. There are technical challenges with a lack of data standards and a proliferation of platforms where it can be hard to find what you need. And certainly there are political challenges with a lack of trust, often leading to restrictive policies. The ClinEpiDB team takes these challenges seriously, and we try to address them with creative solutions. So let's take just one example of how to be fair to data providers. David has already touched upon this, and our policy is to leave data ownership completely in the hands of the data providers. We merely facilitate access to the data. What we do is we curate and integrate data into a private version of ClinEpiDB. And from here, data is never released until the providers decide that they are ready to do so. We also let data providers choose the level of access to data downloads. So Danica showed you how we can look at individual variables and create visualizations, but we also have a tab on our website we can go back and show you where we allow data downloads. And this is individual level data that can be downloaded. And study teams get to decide what level they want this to be at. Public data sets can be downloaded immediately. Data sets that are designated as controlled require that users fill in a data request form saying who they are, where they're from, and why they want the data. And once they submit that, they can download the data immediately. A more stringent level is the protected level, where users will fill in a data request form, and we then forward that form to the study teams. The study teams take several days to review the request and decide whether they approve it, and only when they approve it can the data be downloaded. Finally, I want to point out that ClinEpiDB is a dynamic and ever-evolving project. So here is a sneak peek at what we are working on now. In the coming months, you should expect to see more data sets and additional tools, and especially map tools. That's something that we are very excited about. We are also working on cross-silo integration. So we have various platforms that we showed you, and we would like to allow integration of data across these platforms. The other things that are coming on board soon is a DIY epidemiology platform where you can privately upload your own data sets and use the tools that Danica showed you. And perhaps most importantly, we want to continue to form new partnerships across the globe. The best way to connect with our team is to write to us at help@clinepidb.org. Send us an email. We are very responsive and we want to talk to you. And having said that, I'd like to thank you for your attention, and we can go back and look at any parts of the website that you would like to, or we welcome your comments and questions.
So thank you, Nupur and Danica. Wisdom have taken you at your word, your suggestion that we should try to organize this presentation for something on the order of 45 minutes so that we have plenty of time for questions. Of course, I know from participation in previous H3A BioNet discussions, there's often been helpful discussion. But as you can readily imagine, all three of us would be happy to talk about many other aspects that we haven't had a chance to touch on thus far. I do see in the chat there was a question from Ken Opap about whether there are APIs for accessing these resources, and our database, all of our databases are fully web service compliant, so it's an easy matter for us to work with partners to provide dynamic access for data queries and downloads, as we have done with some of the genomic sites. There are a variety of reasons we have not done so for epidemiology sites, but we would be happy to discuss that. And one of the things that I think Danica was planning on talking about, but which I will maybe mention, and we can demonstrate if you'd like. I mean, maybe Danica, if you want to pull up your screen while I'm talking, you can show people where the downloads are and can illustrate how structured data downloads work. So all of the queries that one can run dynamically, as you've already seen in the illustrations provided, can also be used to structure the data that is available for download. Here, data on the individual data page can be downloaded, and the queries can be used to configure downloads as well. I see that there is also a question from Victor Yontanil about issues related to data import as well as making them fair. Victor, I'm not sure if there are specific questions you'd like to ask. We are certainly strong believers in fair data access, and there are a variety of resources that we hope make these data sets quite readily findable, including search functionality within the sites and ability to find information programmatically. Accessibility is something, and interoperability is something that we are all about, and reusability is the challenge, is the goal for all of this work. One of the big challenges, especially for field and epidemiological data that involves human subjects, even de-identified, is ensuring that these large studies give appropriate recognition to the investigators that have generated the data and the participants who have provided that data. And that's one of the challenges behind making things fully open. But as we touched upon briefly, we do have a series of data access approaches that discourage inadvertent misuse of the data and encourage data sharing in ways that we have seen quite successfully encourage data providers to make their data fully open, as, for example, the PRISM data that I described is fully open despite not being fully published as yet. So I don't know if that answers your question, Victor. If there's more you wanted to ask, feel free to unmute. Let's see, there's a question here from Jane and Jerry asking about whether the output graphics can be downloaded. And indeed, these individual graphics can be accessed. But I do want to emphasize that our goal is not to provide presentation quality graphics. Our goal is not to provide rigorous statistical analyses. We don't expect to put epidemiologists or statisticians out of business. Our goal is to allow study investigators themselves to be able to rapidly explore the data and take a quick look at it, much the same way that with simpler data sets we would use an Excel spreadsheet to look at, even though that might not be what we would publish. Other questions? And I realized that was sort of a hand-waving answer to your question, Victor. I don't know if you had anything further you wanted to ask about fair data access.
I can see there's a question from Begna that is glad to attend the webinar. I'm from Behar, that is university, and where there is a capacity on data science. However, there is a huge opportunity to clinical data. I'm wondering if there is a platform for capacity building.
Yeah, thank you, Begna, for the question. And I think the answer to that is yes, in two different ways. Certainly, we are very committed to education and training, both online, remotely, and through in-person workshops. Some of you will recall I saw Hamadou, for example, from Mali earlier. I knew he will, and others I think had attended a a workshop that we ran in Ghana 3 years ago, just before the pandemic. But there are other opportunities as well. Maybe in a moment, Danica or Nupur could describe what we call the DIY platform for data analysis. But I will also want to emphasize, especially given the heavy involvement of people in this call from the H3 Africa BioNet and the Ilwazi project, that we are looking forward to partnering with additional African scientists extending beyond our partners in Uganda to be able to ensure that the talents of informaticians worldwide can be represented. And there are many projects we want to work on. But we're also trying to make these resources available for people who have their own local clinical studies. I don't know if Danica or Nupur want to emphasize the DIY project.
Yeah, I can touch a bit on it now. So we are actually hoping that a beta version will be accessible for working with your own data sets later this summer. Just a warning, it is a beta version, so I would expect there to be some bugs in it. But the idea is that you would be walked through a process where you structure your data in a certain way, and then you're able to upload it into ClinEpi using a data upload form. And then that data becomes fully accessible on the exploratory data analysis on ClinEpi that I've shown you here. So all of the tools that I've shown you with our curated data sets will be available for use with your own data set. So you'll be able to use the interactive exploration tools to browse and filter your data. And then you could also use the visualization tools to make graphics. And then David, there was another question about—
Yes, I saw there's a question from Ali, and actually your comment on the DIY platform, I think leads right into this one aspect that we weren't able to really address today, but which underlies everything we do, and that is probably the chief challenge in dealing with epidemiological data relative to the genomic data sets we've dealt with for decades now. Is the challenge of appropriately defining the associated metadata. And what's so exciting about the support we've received from the Gates Foundation and others has been the ability to build a strong ontology team who maps all terms to consistent ontological terms in the context of the broader OBO consortium initiative, to try to ensure that when we talk about malaria or diarrhea or asymptomatic parasitemia or traditional housing, that the same terms apply across the studies, allowing meta-analyses of multiple studies. And Danica is showing some results from a site search, which will be rolled out, I think, this week in the next release.
Yeah.
That take advantage of those ontologies for very sophisticated querying. This relates to the comment that Alia Nkala asked what proportion of data is fully open and the data is not, and the linkage there might not be entirely clear. The linkage between this issue of ontologies and data access is that, of course, the access is only useful if it is appropriately structured. And our expectation is that, building on our experience with genomic sites, that as users recognize how well represented their studies are, how easily they facilitate their own analysis with the data, and how valuable it will be to others, that we will exert a pull rather than push mechanism, encouraging broader access to data. So the direct answer to Alita's question, I don't know precisely. As you've seen, there are something like 60 studies that are in process on the ClinEpiDB database. About half of those are currently available in some form. About a third of those are fully publicly available. Another third are available are freely available, but require filing a data use statement with passively approved, typically in 72 hours, and another third require that data use agreement to be reviewed by the study team, and I think 80 to 90% of those reviews have been approved over the course of this project. And the poor Danica can call me a liar if those numbers are wrong, but that's approximately correct. So
no, that's correct.
So there's a wealth of data that's available. I know that you are actively involved in training next generation of data scientists, and there's a lot of data here that people can download now. There's much additional data. Maybe Danica, you were going to show the GEM study. If you want to try to pull that up, the GEM study is a protected study that requires advance approval. But if you look at the study details page and scroll down to the bottom of that, you will see what the requests for this have looked like, and of course the data request forms are more extensive than this, with additional information that is shared with the data providers. But you can see that there are many investigators from various locations who've been interested in exploring that data. So,
Prof, Temba also wants to know if there are any limits to space resources available to users.
Temba, I think your question probably relates to the DIY epidemiology project. So there are no space requirements. So all of the computer analysis here is done on the server side. There are no requirements on the client side for the analyses of these data that have been loaded into ClinEpiDB. For the DIY epidemiology project, for uploading your own data, which of course would be done privately, we would know nothing about it and would not have the benefit of the efforts of our ontology team, although we hope that things are mapped to standardized terms. We anticipate being able to provide that cloud-based storage for that at no cost. My argument to our funders, the Gates Foundation, the Wellcome Trust, the NIH, has always been that if it's important enough to spend the money to spend thousands or sometimes millions of dollars to generate the data, it's certainly important enough to spend a few dollars to make sure that that data is accessible. So for the time being, we are anticipating being able to subsidize that with no costs for storage. We do, when we do this for our genomic sites, where we allow users to map, for example, RNA-seq data, which often consumes terabytes of space, we do put on storage limitations and timeframes that requires people to take their results off within usually a month. I'm not anticipating that that will be needed for epidemiology data. So Temba, I hope that that answers your question. I see other comments here from Victor. Thank you, Aliyah. Any other questions, either in the chat, or people are also welcome to unmute themselves and ask directly if they prefer.
I can see most of the questions have been addressed. I was just wondering, now we have social media. I was wondering whether your lab have social media handles, Twitter or Facebook, that people can follow you, to know what is going on in your lab.
We do, and so I think that whoever is Danica, I think, is sharing the screen at the moment, and she shows the epidb Twitter feed. We make use of a variety of social media for discussions, and are happy to communicate via social media. There are links at the top of the page for Facebook and Twitter, as well as our YouTube channel, where we will post the link to this presentation as well as others.
Yeah, so there's a lot of great resources and video tutorials in the YouTube channel. So they go into a lot more detail on how to do things than we've had time to do today.
So I also see a question from Suliat Abdullahi, which may be a question that others have as well about the prospects of initiating workshops for your students. I have to say, I'm very sad not to be in person in Cape Town today. But the advantage, of course, as we have all learned through the pandemic, is being able to engage people effectively online. And we are certainly happy to work with those at Fountain University or other institutions to try to provide resources. We have a variety of resources available online for exploring these databases. The ClinEpiDB platform is just coming out the far end now of an extensive refactoring of our underlying code. So most of our prior tutorials are out of date, although they should still be comprehensible. And we will be developing new tutorials over the coming weeks and months. But we are also happy to work with individual groups, small or large, to tailor explorations to their own needs. Any one of the three of us or others on the outreach team from the ClinEpi project would be happy to meet with you. The best way to do so is to email help@clinepidb.org or to click on the Contact Us link from this page or from others. And as many on this call know, this is something we've done for many, many years. I was reminded recently, well, I'll maybe close with a funny story. I was recently in Uganda meeting with the PRISM team and was walking back to the Infectious Disease Research Center through the campus of Makerere University. And I was stopped by somebody who asked if I was Professor Roos. And he looked vaguely familiar, but I don't think I would have recognized him. And it turned out he was a student in the very first bioinformatics workshop that I ever ran in Kampala in 1996. So a very long time ago. I'm shocked that he recognized me. I had a little more hair then than I do now. But I was very pleased to see that he was now working in informatics, actually in tick genome informatics, interested in arbovirus, I think in Theileria transmission. I can't remember, but working on tick genomics. So certainly we have a long history of training, and we're happy to work with anyone on this call or in the broader community to try to ensure what the best venue is, either remotely or in person or through online materials.
Okay, Prof, thank you very, very much for taking the opportunity to talk to us today. I can testify to the fact that you've been very busy. As I kept following you and sending emails, it takes a long time before you could respond. And finally, today we have you talking to us. A big thank you also to Danica and Nipur for assisting you and giving us all these wonderful resources. I'm actually from Ghana, and I'm from the Kassina-Nakana area, Nabrongo Health Research Center. I was there working as a field worker, particularly on a number of malaria projects, the malaria gene projects. I worked there before, and then currently here doing my PhD. All the work that we did today, I'm seeing that is being put into these wonderful resources for a number of students that are going on. I would want to thank you for presenting to us these resources. And I'm very sure that a number of us who are here working on different projects and working on our personal projects will see these resources very useful. A number of your contacts and your Twitter handles have also been shared with us. A lot of people will probably follow you and know more about what you have. I'm not too sure if we still have questions or clarifications. And so I would like to thank everybody for taking the time to be with us today. Our next webinar will be coming on the 20th of July. And we will have Professor Oslin Tastan Bishop, who will be speaking to us on missions mutations analysis with applications to drug development. And we have a new moderator who would also be taking over from me, who is also here with me. Melissa will take charge of that next month. Thank you all very much. On behalf of the consortium and the organizing committee, a big thank you to Prof for this wonderful presentation.